Recording from the Sunshine City, St. Petersburg, Florida, overlooking beautiful Tampa Bay, this is the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute. This podcast is dedicated to medical professionals and patients around the world interested in diagnostic and interventional ultrasound. Our podcast will discuss everything ultrasound, from news, trends, career paths, new technology, and industry updates. Hosted by Lori Green and Trisha Rio of Gulfcoast Ultrasound Institute, they bring over 4 decades of experience in the ultrasound profession and are here to guide you through this journey. Now sit back, relax, and enjoy.
Hi, everybody. Welcome to the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute, where we discuss everything ultrasound. I'm Lori Green, and I will be co-hosting today's episode with Trisha Rio.
Hey, everybody.
Today we are discussing musculoskeletal ultrasound because it has proven to be a beneficial diagnostic tool for orthopedics, sports medicine, rehabilitation, and a host of other practitioners. It helps identify structural changes within the tissues and the joints, detect fluid collections, and visualize cartilage and bony surfaces. One of the great benefits is the real-time capability of ultrasound, which allows for dynamic evaluation of joints and tendons and can particularly be helpful in needle guidance and localization when we're doing interventional procedures.
Yep, and we are so excited to have with us today Dr. Charles Stevens. He's going to join us to discuss how he is integrating MSK ultrasound into his physical therapy practice. Dr. Stevens is a doctor of physical therapy and the owner-operator of Mobile Therapy Services in Dallas, Pennsylvania, which is a geriatric outpatient therapy house call practice. He has a passion for geriatrics and evidence-based therapy. In January 2023, he earned his RMSK credential, which is the highest level of proficiency in diagnostic ultrasound. Welcome, Charles.
Happy to be here on the show with you guys and happy to share my passion with diagnostic ultrasound with our viewers and listeners.
Thanks. Yes. We're so excited to have you here. So why don't you begin by telling us just a little bit about what prompted you to pursue your training in MSK ultrasound and also go on to get your RMSK credential?
Great. I have to give my credit to my girlfriend, Dr. Trisha. She's a hospitalist and she's the one that, mentioned to me about diagnostic musculoskeletal ultrasound. I was at some conferences and I was aware that physical therapists can do it. And I was like, wow, this is a really neat modality. In terms of physical therapy, we're looking to be different. There are a lot of therapy providers in our area, and I knew that this would be something that would differentiate my practice from all of the other practices here in northeastern Pennsylvania. So it was a really big practice and differentiator. Patients love it. If I can show them, they're like, hey, it hurts here on my shoulder. I can show them, well, like, hey, you have a rotator cuff there. There's a joint swelling or there's arthritis. It really helps with the patient experience. And it has really changed several patients' medical care, but we found rheumatological issues such as gout in people's joints and infections in joints and that kind of thing. So without the ultrasound, the person might have had more complications with their health. And because we were able to do it, it strengthens the relationship with the physician community, and also it's changed people's medical care directly, for sure.
That's awesome.
That is so awesome. And I'm sure that for your patients, that they definitely appreciate the ability of being able to actually see what's going on with their joint or their tendon or their ligament and so forth, so that they have a better understanding of why you're doing the physical therapy and the process of their healing.
Yep. The patients absolutely love to see what's going on, to see inside the body like that and to be able to move, because no other real form of imaging the patient can move. And PTs, we really are the musculoskeletal experts and movement-based experts in the medical community. Mm-hmm. So for us to be able to do this and have the patient move and do special tests or even teach people how to activate muscles with imaging, like with the transverse abdominis, I could have this on Trisha's abdomen, and I could teach her how to activate her transverse abdominis muscle in the abdomen. It helps for lower back rehab. We could also get cross-sectional area of like the multifidi muscles in the lower back. The person can start therapy. I could measure the thickness of those muscles, treat them for 6 to 10 weeks, go back and re-image and measure the hypertrophy so it's really cool stuff, and patients love it. Doctors love it. We have people that come with plantar fasciitis. I can measure the thickness of the plantar fascia. More than 4 millimeters would be indicative of plantar fasciitis, and I can treat them, measure them the first day, and go back and re-measure them, 4 weeks out, 8 weeks out, And I have pictures of people's plantar fascia where we've treated them and the proof's in the pudding. Their symptoms got better, but the thickness of the plantar fascia diminished as the tissues were offloaded. So no other, else in medicine, I don't think we're going to see this kind of movement-based imaging. And the PTs are really, if we can do it, it makes sense for our profession to image these people. And I have some really, really cool case examples as well that we'll talk about, where you would see pathology on the imaging, and we might see Casey. He might say, "Hey, Charles, my elbow really hurts me." And we might find tendonitis in his elbow, or maybe a radial collateral ligament tear. Maybe the pain's coming from his neck. And even though we see pathology in the elbow joint, that doesn't mean that's where his elbow pain is coming from. So we got some really cool examples here coming up.
That's so awesome.
I know. And it's funny because you always hear this saying, knowledge is power. But I think in healthcare, knowledge is compliance, because when patients are informed, they tend to be more compliant with their treatment. They tend to stay more on plan with, what you have them doing. And then, patient satisfaction is a huge thing for especially companies like yourself, business owners where you're a small practice, you don't have a huge corporate backing. So having satisfied patients is super important. And I can imagine that showing them their before and after, even though they're like, oh yeah, my symptoms are better, but seeing it before and saying, okay, I'm buying into this treatment, and then seeing it after, I'm sure that brings your satisfaction scores through the roof.
We have very low. So commonly in outpatient physical therapy, there's issues with patient compliance, people dropping off, not completing their plan of care. We don't have that problem. People come and they would bring their friend, their family, their spouse. We have about a 2 to 3 month waiting list right now, which is a blessing, just partly due to the ultrasound that we're doing. It's, people leave other therapy practices to come here because we can do it. And it really, it's a game changer. And the physician community loves it too, because I know when to pick up the phone and call the orthopedic surgeon or the rheumatologist or the primary care doctor. It's really changed some people's outcomes and trajectory of their healthcare.
Yeah.
Fantastic.
Well, I know that you and I came to get to know each other a lot better because you took on the grueling challenge of earning your RMSK, and you were part of our Facebook group for those preparing for their registry exams. So can you just tell us why you believe that physical therapists should pursue training in MSK ultrasound and go on to achieve the RMSK credential?
Yes, for sure. Yeah. So, we already talked a little bit about why physical therapists. We are very optimally positioned. Unfortunately, with primary care and the shift of payment structures for primary care physicians, they don't get a lot of time to spend with patients. So Trisha goes in to see the primary care doctor or an orthopedic surgeon, and she has shoulder pain. They may do point of care ultrasound. There's not a lot of that being done in my area right now, but with the PT, we do diagnostic ultrasound and also screen out her cervical spine and make sure that her shoulder pain is not coming from her neck. So I think it makes sense for physical therapists to learn it, especially with the movement-based stuff. It also has roles in terms of, neuromuscular re-education with, lumbar stabilization with transverse abdominis activation. Really, really cool there. The RMSK, I think, we haven't really gotten a lot of bad feedback from referral sources or physicians in our area, but it's different. Like, we're thinking outside the box. Like, a physical therapist doing point of care ultrasound, like that would be like 20 years ago. If I said you can go on your phone and go on Amazon, you'd be like, Charlotte, that's crazy. I don't need a phone to go on the internet. I have a computer. Look at it now. Yeah. So this is at the cutting edge of medicine. Northeast Pennsylvania, I'm changing the way that the medical system is thinking about physical therapy, and we do have direct access. We can treat for up to 30 days without a referral. So, Lori comes in off the street, I'll be able to, she's pain in her foot. She's a runner. Does she have a stress fracture? Is this something I need to triage or get further imaging on? So it makes a ton of sense for point of care direct access, which we do have here in Pennsylvania, and Florida does as well. The RMSK, it makes sense. I mean, the general public would not recognize what that is, but peer-to-peer, we've had orthopedic surgeons. We had a patient with a total hip replacement that had ongoing pain. I picked up the phone and called the orthopedic surgeon. I said, hey, this gentleman has a partial thickness tear of his rectus femoris, a direct head originating off the anterior iliac spine. He had a previous hip replacement, and he had to go back in and pinned it. He had some other crazy pain going on, and I knew there wasn't something right going on within this hip. I kept referring him back to the physician, and he is going for he went for a second opinion, and now he's going to Philadelphia for, unfortunately, another surgery on this hip. So peer-to-peer, I mean, it makes sense. It would be like if I told Casey I play piano at Carnegie Hall, he'd be like, hey, Charles knows his piano. Like, peer-to-peer, it makes sense, and I can have those conversations. I've called some radiologists where we found about, I think, in one of Dr. Jacobson's lectures, he talks about peroneal nerve cysts causing foot drop. I found that in several people. We've sent the people for MRIs, and I've picked up the phone and called the radiologists and reviewed imaging reports with them, and it helps with that peer-to-peer discussion that, hey, Charles isn't fly by night and picked up an ultrasound probe and started waving at people. He did his due diligence and put his time in, and you guys had a great program. I did purchase John Jacobson's practice exam, which really I think was instrumental as well. And all the in-person training we did last August with your live seminar, that was helpful too. And I think I urge PTs to get it. Right now, there are some reimbursement issues for us to get paid with this. And I think the more advocacy we do and the more people that have this, it will be like ECS, which PTs can do EMG and nerve conduction studies, but they have to be board certified in that. We need more PTs to do this, that we can go back and advocate to Medicare and to insurance companies that, we really are qualified to do this and that we should be paid for our movement knowledge and expertise. And particularly once we get to the case examples of, hey, I'm ultrasounding these people. They're coming in. Charles, my foot and ankle hurts. The lady didn't even have any back pain. Part of her foot and ankle pain was coming from an L5 nerve getting compressed in her lower back, causing foot and ankle pain. That's a quick story I was going to delve into, where we had a patient come in, referred by orthopedics. The patient had foot and ankle pain. She had a Haglund's deformity on her calcaneus. She had some extra bone there that was pressing on her Achilles tendon, causing foot and ankle pain. She came in to see me. She didn't complain of any back pain. I ultrasounded the symptomatic heel, and I ultrasounded the heel that did not hurt. She had a larger bone spur on the asymptomatic limb, which is even crazy to think about. I had her lay on her belly, and I palpated her L5 facet. I said, does that hurt? And she said, yeah. We previously palpated her Achilles tendon and the Haglund's deformity, and she was tender. I treated her lower back, and I went back and repalpated the tender spot on her heel, and her pain went away. Mm. She went back to the ortho and was like, Charles treated my lower back and my heel pain went away. He's like, what? Like, that wasn't even on their radar. It wasn't even like, so that's the benefit of physical therapy. And her ankle looked awful. Like, there was an awful osteophyte, and the Haglund's deformity was horrendous. But like, the lady went back to teaching Zumba. She's a Zumba instructor, teaches 2 or 3 days a week. She's pain-free at this point in time and avoided a surgery. And we talk about cost saving to Medicare and to insurance companies. I saw her maybe 3-4 times, point-of-care ultrasounds. Maybe they spent $500 on this lady's therapy. One MRI would cost 8 times what this was, and we fixed the problem without surgery, injections, or medication. Wow. So I get fired up. Yeah. So I urge any PTs listening, I do urge them to pursue formal RMSK and then to look you guys up and purchase some of the practice tests. It's hard. It's harder than the PT boards. There's a ton of physics on it. It's a challenge to do it, but it helps with peer-to-peer recognition. And one of the reasons I wanted to do it was to teach other medical providers. And I think that the RMSK would be a peer-to-peer recognition of like, hey, like, Charles has done his due diligence.
Wow, that's awesome.
Absolutely. Well, there's no doubt about it. Being certified, it demonstrates your proficiency levels and your credibility. It helps, like you said, with your peer-to-peer discussions, but also giving, even though a patient might not know exactly what that entails, they at least know that you've gone through the process of taking
formal
a national
training,
board and some formal training, and that gives them more confidence and in what you're telling them and showing them on an ultrasound. So, and then just the fact is, MRIs are a lot more expensive. You can't get the dynamic imaging that you can with ultrasound, and the ability to be able to do that at the bedside in conjunction with your physical exam, and can really shorten the time frame that it takes for them to get their treatment and effective results. So, and money. So, there definitely are many, many benefits to be thinking about integrating the use of ultrasound into physical therapy practices for sure.
Yeah. And congratulations to you.
Yes.
You worked so incredibly hard to earn that credential, and
Thank
you
you,
were
thank
so active in that group. Every day I was just like, there's Charles.
Like, Charles has messaged me again, questions. Dr. Jacobs is probably like, Charles, is there any more questions about ultrasound? But that's
At
how
the
you
end,
learn.
at the end, he said, you should just give him my email address. I'm like, okay. I'm sure he has it in his syllabi.
I won't blow him up too much, but he'll love to see these case reports we have with the pictures and what I did to help these people. I can't wait. We'll have to get him a copy of this webinar.
Oh, for sure.
Yes.
Yeah,
I'm actually
absolutely.
talking to him right after this podcast, so
Oh,
I'll make sure that I mention.
Yeah, absolutely. Yeah, well, that kind of transitions into our next question about utilizing, giving us some patient examples where MSK made a change in the trajectory of the patient's treatment and physical therapy.
Yeah, you've got some good cases for us, right?
We're excited to see
Yeah,
that.
Yes.
we have some good cases. The first case, all these patients have given consent to share images, share their likeness, share their story. They're very passionate about the physical therapy they received and also the imaging where, it changed some of their medical care. So the first patient was a former professional football player. As you can imagine, he's pretty banged up. He's over the age of 50, big dude, loves lifting weights, never wants to stop training. And I love bodybuilding and lifting too, so we kind of bonded over that. He came in and was complaining of shoulder pain. I did do a diagnostic ultrasound on him, and we'll share my screen in a moment. He had large full thickness tears of supraspinatus and subscapularis with a large joint effusion in the long head of the bicep, which shout out to Dr. John Jacobson. The long head of the bicep does communicate with the shoulder joint. So we saw some, so we have these images of, and it looks absolutely horrendous. If we show these images to Dr. Jacobson, he'd say, hey, when is that guy going for surgery? And I have a before video of him moving the arm. We have an after video of him moving the arm. And I not only treated the shoulder, but some of his pain was coming from his neck, even though he didn't complain of much neck pain. Also, he had some symptoms of thoracic outlet syndrome where I did mobilize his first rib and some of the upper ribs around the neck and the brachial plexus, which immediately took some pressure off some of the remaining musculature. So I think probably physiologically what happened, we took some pressure off the brachial plexus. There are protocols in physical therapy to retrain the deltoid muscle to compensate for full thickness tears of the rotator cuff. So he was so strong in his deltoid, and I think by mobilizing the mid-cervical spine, particularly the C5 nerve root, we helped neural efficiency to the deltoid and the remaining rotator cuff musculature to eliminate his pain and range of motion deficits. So I guess I'll share my screen. Why don't we start with the video? A picture's worth 1,000 words. So I'm going to pull up the video here and share my screen. So I'm going to mute there you go. Good. So here's my patient the first day. Obviously you can see it's his right upper extremity. I asked him how much pain did he have with that, and you can see he's clearly grimacing. It was severe pain. So we treated this gentleman a handful of sessions, and you can see the fact that he can abduct his arm at all, once we see these pictures, is pretty astounding. So here's a little backstory on this gentleman. 4 sessions of physical therapy. Here was our outcome.
Whoa.
His pain went away. And he's shaking. I said, do you have any pain? He shook his head, no. He's not grimacing. And then he talks a little bit about his therapy and what we did and our outcome. So why don't we take a look at maybe some of his images? So I'm going to minimize that. And we have a few images here. Can everybody see these images?
Yes.
Yep. So unfortunately, I did mislabel this. This is a long axis view of the subscapularis. So we have this anterior deltoid muscle, which probably is what was compensating for the full thickness tear. Here's some remnants of the greater tuberosity with cortical irregularity, a thickened subacromial subdeltoid bursa. Not much fibers are coming across through this area. He had a large full thickness tear of his subscapularis. I did get a short axis image of that as well. There's one bundle of remnant of fiber here, but he had really large tears of the full thickness through the subscapularis. His supraspinatus, I'm going to try to get that up here. And here's another short axis view of the subscapularis, scanned a little bit inferior to the greater tuberosity. This is more of the muscular attachment onto the humerus. So again, we have overlying deltoid and just a hollow concavity of the subscapularis muscle belly. We're going to come into his supraspinatus. This picture really says a lot. So, as Dr. Jacobson pointed out, cortical irregularity along the greater tuberosity is not a good positive sign of an intact cuff. We have his overlying anterior deltoid. We have his thickened subacromial subdeltoid bursa. We have a little bit of a cartilage interface sign here with fluid underneath, some part of a tendon, and there's really no tendon fibers coming across into the greater tuberosity. We have a short axis view as well of this gentleman of supraspinatus. So we have part of the rotator interval. There's the long head of the bicep. There's really not much supraspinatus fibers here at all. So 4 sessions of physical therapy, and we resolved his pain, and that was in the presence of a very, very large tear. We do have another example I could get into. We had a patient, it didn't particularly change his medical care a ton, but the patient's name is Roger. Here's a picture of Roger. He's going to be famous. I told him he'll be on the webinar. Here he is. So he's sponsored by New Step. I'm teasing him, but he came in, he had knee replacements and developed some arthrofibrosis of his knees. He came to physical therapy with about 70 degrees worth of knee flexion years after the total knee. I've worked on him. We treated not only his knee, but his foot and his ankle, his SI joint, his lumbar spine, both his hip capsules. I've got him to about 85 degrees worth of knee flexions. He's almost able to get out of a chair a little better. The ultrasound came in. His first day of physical therapy, this gentleman came in, and here's what I saw. He said, I was getting on the back of my ATV, and I heard a pop. And this is his popliteal fossa. I said, wow, I've never seen anybody rupture a hamstring. I said, well, why don't we take a look? So we start scanning them. So I have some images here. So this is a short axis view of his semitendinosis. There's a fragment of avulsed bone that peeled off from his ischial tuberosity. This is where that semitendinosis would be residing, some of the conjoined tendon above. Here's where the semitendinosis would be. And there was nothing on color Doppler that we saw, so that's remnants of where in the fascia that semitendinosis would be residing. We have another long axis view of where the semitendinosis would be, and there's nothing. There's no fibers there. And we have another short axis view of where the semitendinosis would be with, again, an avulsed bone fragment from the ischial tuberosity. Believe it or not, this gentleman has no pain. He had a full thickness tear of the semitendinosis with retraction and a bone fragment that did come off with it. He's pain-free. We are still working on his knee range of motion. If I never ultrasounded him, he never would have known he ruptured the tendon. It didn't really change his medical care, but I did call his referring physician and say, hey, FYI, Roger did, have a full thickness tear of one of his hamstring heads, but he has no motor weakness as a result, and he's still participating in physical therapy.
Wow.
So,
Those are great cases.
Mm-hmm.
Thank you. I'm trying to get back into there we go, and I'll stop sharing my screen.
All right. Just great. I took a lot of notes while you were talking, so I have to put this all together here. So on your first the rotator cuff that you did with Jerry. So full thickness tear, you saw the cortical regularity. Explain to us why that cortical regularity is so important.
I think it's on 75% predictive value in terms of tearing of the supraspinatus, especially at that footprint. So it's really showing that especially on the articular surface, that the supraspinatus has torn those articular fibers. His did extend all the way from the articular surface up through the mid portion of the tendon into the bursal surface. So if you see that on ultrasound, it's a giveaway that there definitely is pathology in that supraspinatus tendon, and very predictive of tearing of that subsequent tendon.
Yeah. Mm-hmm. All right. Do you have any questions, Lori?
No, those were great.
Those
Great
were
cases. And, I think I think the importance of in particular, the shoulder cases, there's so many people who have full thickness tears, and they think their only alternative is to go to surgery, and that kind of outlines that there are some other possible things that they can do, such as physical therapy in the hands of the appropriate clinician, and that they maybe could avoid having surgery. And then there's other techniques, regenerative medicine and things like that. But typically, the thought process, at least in the patient population and some of the providers that are out there, that this is basically gone and you don't really have another option but surgery. But it's great to see that you've got a before and an after, and this isn't like the only case, that you've been able to help your patients through using ultrasound in combination with your physical therapy to get them where they need to be. And I know we've had a couple of our standardized patient models in the past that, they're a little older, they're in their 80s, they love to play golf, and next thing you know, they've torn their rotator cuff and full thickness tears, and they've gone on to have some physical therapy and are back to playing golf when they've been told you're going to have surgery. And shoulder surgery is not, at least, I know many people have had rotator cuff surgery.
Let's be real.
And it is not fun, right?
And it doesn't have a great success rate.
Right. And it's a lot of therapy, right? It takes a while.
It's a lot. It's painful. I think the data point might be something along the lines of like 2 out of 3 people over the age of 65 have rotator cuff tearing, even in the absence of pain. It's a normal finding. So there's imaging that's done on asymptomatic people in the population. We're very surprised who comes in, and we see crazy stuff with the ultrasound, and I might treat somewhere else in the body, even knee issues. You'll see meniscus tears and, arthritic changes to the knee. We have a lady right now on the caseload, very arthritic knee, severe tricompartmental arthritis confirmed on x-ray. I have her sit on the edge of the physical therapy table. I say, hey, Barbara, can you hold your knee out? I push on it, and she's like, oh, that really hurts. Have her lay on her belly. I treat her lower back. Go back, have her sit on the edge of the table and push on her knee again. And she's like, oh, my knee pain went away. So that's another case where even we could ultrasound her knee. She's in her 80s. It's not going to look good. It's like if you cut down a tree that's 80 years old. It's got rings on the inside. Her knee pain's not coming from the knee. I treated her. She canceled a total knee replacement. Her pain is still partly coming from her lower back. She's doing great. She goes to the farmer market and deadlifts watermelons off the ground or something to kick the butt.
80. I love it.
Yeah. She's a hoot. So it's interesting, there's not a lot of people in medicine right now having a patient in front of them, ultrasounding them, doing a physical exam, and then putting their hands on the patient and treating somewhere aside from where they ultrasounded, and like observing like, hey, how does this respond to their concordant complaint and symptoms? So any PTs listening to this, I would urge them to get training and pursue RMSK and formal education in this.
Yeah. They can join us. We got courses coming up. So
absolutely.
GCUS.com. Come on. We're more than happy. That's right. Florida's great right now. The beautiful weather. And it's been really nice. Well, I mean, I just, we've heard a lot of cases and a lot of situations where referral pain is a real thing. And if you understand how the spine works and how the spinal cord works and how messages are sent, this makes total sense. And why would we not move toward working as a team? I mean, I understand surgeons are surgeons and that's what they do. They do surgery, but we're looking for the best outcomes for our patients overall. And at the end of the day, wouldn't it just be worth the time to say, okay, let's go ahead and put you through 6 weeks of physical therapy. Let's just see what we can do. Let's make sure that the surgery is actually going to do what we want it to do. For example, the total knee replacement. That's not the first time I've heard that, that's not where the pain was actually coming from. I think even Dr. David Wang went through that the last time he was here with us in January. And so why wouldn't we just start with the most conservative method and just keep working our way towards the surgical technique as last option? Right?
That's the hardest part with our profession. We have people, we had a patient come in, one of our working at church, it's one of our choir members. He has an HVAC company. He fell off a ladder, landed on his arm. He said, hey, Charles, can you do therapy on behalf of my rotator cuff repair? I said, can you come in first? Like, can I take a look at your shoulder? I treated his neck and I did treat the shoulder some. His pain went away. He canceled a rotator cuff repair. He works in HVAC. He's working overhead all day. That arm would never be the same. Therapy was never prescribed to this patient. He fell, they did an MRI, they tore the rotator cuff, go to surgery. The biggest problem with physical therapy or the healthcare right now, we're not part of the decision-making process. And it's awful. And that money comes from somewhere. I think the data point in 2021, as a country, we spent 25% of all of our healthcare spending on medication that was later deemed unnecessary, some of that pain medication. That 25% was more than all of conservative care, physical speech, occupational therapy, chiropractic, and podiatry combined. We don't have a physical therapy problem in this country or an ultrasound problem. We have a medication and procedure problem in this country. Those procedures are going up and up and up. PT, we keep getting cut every year by Medicare, and we're trying to survive. We're not the problem. We need to be more of the front line of musculoskeletal health. And hey, Mrs. Smith comes in, she's got a rotator cuff tear. I treat her for a month and she's no better. Okay, go to ortho. Maybe you need a rotator cuff, repair. But not that often are people leaving me and then going for surgery. We're fixing their symptoms enough that they're like, hey, I'm pretty good. I'm 80% better. Or like that football player dude, he's lifting weights. He's doing some modified shoulder work. He's happy. If he got a rotator cuff repair, maybe rupture, you can get infection, and he would be out of commission for a long, long time.
Right. Yeah. It's a change of mindset and, kind of thinking outside the box, recognizing that there are non-surgical options and, allowing your patient to be able to experience that before moving on to something that's a procedure that's has higher level of risk, higher time away from work or play, and
that's exactly it. And this is exactly why when we heard what Charles had to offer us today, we said, you have to come on our podcast.
Yeah. Because it's also, knowledge, and this will be helpful. We have many medical professionals that are listening in, but we also have the, public, just general public listening in. And the more that we can help to educate them on what their treatment options are and diagnostic options are, that everybody's just used to MRI and that's it, and they automatically think I got to get an MRI, but I think that this is just a stepping stone, and it's time will tell. But I'm sure that the use of ultrasound has expanded exponentially across so many specialty practices, and I think it's going to continue to do so. And I think physical therapy is definitely an area where once people become more knowledgeable about the benefits of integrating it into clinical practice, that they'll wonder why they didn't start doing it.
And they're
earlier.
getting more knowledgeable every day out there. So,
yeah.
Well, we have a lot of hand stuff. We treat a lot of thumb, CMC joint arthritis, first wrist veins, tenosynovitis. Ultrasound, we'll ultrasound that first wrist compartment. We'll see tenosynovitis. We'll press on it. It'll hurt. I might go up and start treating the lower cervical spine, C6, C7, the C8 nerve roots, where they're exiting between the vertebrae, the set joints. A lot of times that thumb pain and thumb arthritis goes away. Yeah. Even though on ultrasound, you put that probe on there, it looks awful. There's cortical irregularity and joint swelling, pain and weakness moving the thumb. Get up and start treating some restrictions in the first rib and the lower cervical spine. A lot of times it goes away. So it's crazy, and how many of these people are going getting injected or, getting joints replaced in their thumb, and, maybe it's coming from their neck. It's crazy stuff.
Yes, it
absolutely.
is. Well, I guess we should wrap up with one final question. I mean, I think I know where I see you, but where do you see yourself in the future in regards to physical therapy and MSK ultrasound?
Yeah, so I'd like to share my passion with other medical providers to help teach, other PTs, physician NPs, PAs, orthopedic doctors, rheumatology, to help get the word out. And even what I bring to the table is the thinking outside the box of, don't get so focused on the patient says, hey, it hurts in my elbow here, and we're scanning there. Even though you see something, that might not be the problem. So I do want to, teach, and I reached out to our local university here to help me be part-time there, and opportunities to help further this in the medical community and teach other people and share my passion with that.
Yeah,
Great.
and we're looking forward to having you come down to Gulfcoast Ultrasound and teach with us.
I'm ready.
That's right.
We got people. So anybody listening to this, I want you to now minimize your browser and go to GUS's website and sign up for the August class. So shout out to everybody listening. Yeah, go sign up now, and Tori will be happy, and then you can meet me and learn all this crazy stuff with ultrasound and thinking outside the box with some of this medical care.
Oh,
Thank
you're
you
awesome.
so much. Yeah.
Yeah.
Well, we've seen an increasing number of physical therapists coming to our program. So,
Yep.
we love having everybody come, but we'd love to see more physical therapists come as well. And we're growing rapidly with that
Yeah.
application. So,
They're a fun group to work with.
yeah, absolutely. All right. Well, it looks like we're about out of time. So, Charles, thank you so much for joining us today. Those were great case examples, and really enjoyed hearing about how you're using ultrasound in your clinical practice and sharing all of this great information with our listeners.
Yeah, absolutely. Thank you so much, Charles, for being here with us today. We really appreciate it and appreciate you sharing those cases with us. We also want to give a big thanks to our listeners. You want to be sure to check out this episode on our YouTube channel so you can actually see the cases he presented today during today's episode. And if you have a great idea for some content, we do encourage you to send that to us at sonographylounge@gmail.com. We want you to have a great day and happy scanning.
That's right. Happy scanning.
Thanks for listening to the Sonography Lounge. Don't forget, if you like this episode, please subscribe and leave us a review on iTunes, Spotify, or wherever you get your podcasts. You can also find us on Instagram at Sonography Lounge and Twitter at SonographyLNG. If you have any questions, comments, or topic suggestions, feel free to send an email to us at sonographylounge@gmail.com. Have a great week and scan, scan, scan.